evening, everyone. Thank you very much for joining us on our session today. We're looking at the importance of newborn screening. My name is Moa Chisenga. I'm your host today, and with me I have Dr. Catherine Chunda Liyoka. She's a consultant pediatrician and honorary lecturer at the University of Zambia, my home country. So yeah, very excited to hear what's happening back home in the sickle cell space. So welcome, Dr. Catherine.
Thank you very much. And thank you for the invitation to make this presentation.
Fantastic. Well, without taking up too much of your time, I will hand you the floor and you can take it away.
All right. Thank you very much once again. So we're here to discuss the importance of newborn screening, and particularly we're talking about newborn screening for sickle cell disease, or indeed for hemoglobinopathies. I'm the focal person for sickle cell disease in my country, and actually chair of the National Task Force for Sickle Cell Disease at our Ministry of Health. And so just to begin, we ask ourselves the question, why do we have to screen for sickle cell? Okay, I'm trying to see. Okay, so we ask ourselves as we begin, what is newborn screening? So newborn screening, in a lot of instances, is a program that has been introduced for screening infants shortly after birth for conditions that are treatable but may not be clinically evident at the time a child is born. Through this particular process, you're able to identify a lot of inherited hematological disorders. This is an activity or a program which is being done in quite a number of, high-income countries. And these programs are usually supported by government funding, public education, and usually health workers are trained to perform this particular task. And sickle cell disease indeed is one of the diseases that is actually screened for through this particular program. The reason why we particularly need to screen for sickle cell disease in African countries, or indeed low middle income countries, is that sickle cell disease is actually reported to occur in 85% of the cases that you see. They tend to occur in these African countries. And unfortunately, very high early mortality has been reported, this mortality ranging from 50 to 90% of children who mostly die from infection and severe anemia. Diagnosis is a challenge in most of these countries in Africa, in that treatment is scanty and many a times programs are just non-existent. So newborn screening and early intervention programs are quite limited. Very few countries have these programs in place. And even when they are there in place, they are quite limited in their scope. They are quite limited as well in that they may only screen a single disease within a restricted population that has access to healthcare. There's also very limited awareness about the disease in terms of signs and symptoms, not just within communities, but even amongst the health workers. In terms of just epidemiology of this disease, globally, it's been reported that about 20 to 25 million people are actually affected with sickle cell disease. And WHO has given some estimates to say you have about 150,000 to 300 individuals actually being born with the disease in Africa alone. This gene for sickle cell disease has actually been reported to be quite varied in different countries within Africa, ranging from 5 to 40% of populations. There are those figures that have been shared in Zambia. In one particular area of the country, there's been a trait prevalence of 15.5%. reported. In Kenya, 17.1, Tanzania, 13%, DRC, which is one of the neighboring countries, 16.9, and Malawi, in a very recent paper that was published this year, they reported 9.1. So we can see that we have areas where the prevalence of the trait is quite high, and yet we don't have comprehensive control programs in place in all these different countries where information has been shared. So WHO has actually recommended that there's need for developing national sickle cell disease control programs that should include all these facets. There should be advocacy, there should be prevention and counseling programs, there should be early detection, and that's where newborn screening comes in. Once these children are treated, there should be treatment availed to them, and also surveillance to find out the burden of the problem in these areas. There's need for more research, community education, as well as partnership so that these programs can actually move forward. So indeed, you can see that there's need for developing these national policies and protocols that are locally appropriate and acceptable, taking into consideration what we have available on the ground in these particular areas. So newborn screening is something that is relatively new in most African countries, and what you see in most of them is their piloting studies, most of which don't translate into sustainable nationwide newborn screening programs. So we have these few countries that have, in some cases, published and shared information that they had collected as they were carrying out these pilots. And we have, for the countries that have highlighted, these are countries that have ongoing pilot programs with the aim of actually demonstrating to the Minister of Health that these are things that are feasible to introduce, they're cost effective, and it is possible for them to roll them out to the rest of the countries. And so what would really be the benefit of doing newborn screening? The benefits are several and at different levels. I think at policy level, it is important that the prevalence and the distribution of these conditions are known. This would actually serve as the first step for them to begin to design intervention programs and to be able to know where they should target these programs to screen, to diagnose, and to manage the disease, particularly in areas that are high risk. At hospital level, it is important that we identify this disease quite early as clinicians, because we know there are very low cost interventions that we can put in place to ensure that ultimately the risk of morbidity and mortality are reduced in these children. So we have interventions such as penicillin prophylaxis, immunization against encapsulated organisms, and one very simple thing we can teach our parents to do is be able to feel the abdomen of the children and be able to identify the risk of their child having an enlarged spleen, a condition which carries a very high risk of mortality. These very simple measures have actually have been attributed to the very high survival rates that have been reported in the US and other developed countries. And that is why there's the interest actually to take them up. Once a parent or a family, a household knows that their child have the disease early, their understanding of the disease, their knowledge, their ability to contribute towards caring for this child is something that can be secured quite early, so that this would allow the parents to be able to note any complications the child will develop early and seek help, thus enabling at the end of the day the child to live a healthy life. It reduces the anxiety, of course, that goes with parents having to seek help from several health facilities before they finally get the diagnosis for this particular child. So they would be diagnosing the child quite early before the child even begins to get sick. and begin to anticipate the problems. Through this newborn screening, families have also been able to pick up risk factors in the family so that they can make a choice as to whether they should continue to have children or not, or whether indeed they should um, they should marry at all. Those, of course, are very difficult decisions to make, or even anticipate a parent, a child that they're expecting to have possibility of having the disease. Some of these simple, inexpensive, cost-effective interventions I did mention penicillin prophylaxis, but you can also give folate prophylaxis. In areas where malaria is endemic, it is possible to give anti-malarials to prevent malaria and anemia as well. In some cases, through the same newborn screening program, some countries in the earlier paper I'd mentioned, which was published from Malawi, it was reported that they were actually able to pick up 40% prevalence of alpha thalassemia and G6PD deficiency at 20% of the patients that they actually screened for sickle cell disease, which was found to have a trait of 9.1% and an incidence of 0.1%, figures which are actually expected within the countries around those areas. So these are some of the things that through research have actually been proven that a child is able to survive when they are identified at birth with the disease than when they're identified in early childhood. So you actually begin to appreciate the interventions as early as that. You have an increased chance of survival of a child of between 95 and 100% when they're actually diagnosed as a baby, as opposed to when they're identified in early childhood. It's also been proven that receiving prophylactic penicillin soon after birth results in a less likelihood of having fatal bacterial infections. So in that graph, you see the cumulative probability of infection in a child who receives placebo and one who receives penicillin. And you can see the difference there is quite significant. We also have vaccination. You can see again in that graph that children that have received PCV and those that have not have a significant difference in terms of having invasive pneumococcal disease, with those that have not having a much higher chance of having significant invasive pneumococcal disease. So this is actually research that has been done to actually prove this point. We have at the moment a program that is running within 7 countries in Africa. This is a newborn screening program, which has an abbreviation CONSA. And this is a consortium for newborn screening for sickle cell disease in Africa, a consortium that has been formed by the American Society of Hematology with the aim of actually establishing newborn screening and early therapeutic interventions for babies with sickle cell disease in sub-Saharan Africa. These interventions are being instituted within a network of these CONSA participants for basically the prevention of early mortality. So there's also, aside from the diagnosis, early intervention protocol with administration of antibacterial and antimalarial prophylaxis, as well as vaccinations. Within this program, they'll actually be able to evaluate the effectiveness of these simple interventions that are being alluded to here, diagnose a child early, put them on a treatment regimen or protocol where they receive antibacterial, they receive antimalarial, as well as getting vaccinations as well. And underway are discussions to introduce hydroxyurea within this particular network. So those are the very specific objectives of this consortium. And you can see on one side the countries that are involved, being Liberia, Ghana, Nigeria, Uganda, Kenya, Tanzania, and Zambia. The very specific objectives are to establish screening of 10,000 newborn babies for sickle cell disease within each one of these countries, establishing a shared early intervention and follow-up clinical protocol, which has antibacterial, anti-malaria prophylaxis, as well as vaccinations. Within the vaccination, the minimum should be at least vaccination against pneumococcal and Haemophilus influenza. These networks have also established a registry that uses an electronic database that captures information on these children from the time they're recruited and will be followed up for a period of 5 years. So this is just a picture to basically tell the story of Zambia, which is part of this consortium. And as of 21st of April this year, the newborn screening program was launched with support from the American Society of Hematology and was actually launched by our Ministry of Health with lots of support from ASCA as well. You can see one of the pictures there where there's a mother and a baby. That was one of the launch captions that was put there with support from the parent and the patient support group. You also have further on the right, the top right, the first group of health workers that were trained in the care of sickle cell disease and also newborn screening in one of the institutions that is taking place where I'm based. The other one being the middle right corner in the northern part of the country where that was done. The two middle or three middle pictures in this caption here. On the far left is actually the central laboratory that has been assigned for doing a newborn screening program within the countries. The next picture are the 4 nurses that actually are involved in this particular program, 2 from each one of the 2 centers that are involved. And the next one is actually the launch itself, where we had the Minister of Health of Zambia actually launching the program. The bottom picture is actually just another one showing a picture that we took just after the launch as the minister was going away. And since all this has been done, we've also had 2 new sickle cell disease centers that have been established within 2 government institutions in the northern part of the country, where the prevalence of the disease is actually reported to be very high. And with this, I actually end my presentation and are ready to take on any comments and any questions that may come from the audience. Thank you very much for your attention.
Thank you, Dr. Catherine. I'm very, 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 very encouraged. You see the smile inside my heart about the awesome work you are doing in our home country, Zambia, and the progress that's being made. I am going to have a look to see if we have any other questions, but I have a few questions of my own, if I may. And I'm just thinking, I guess, with what you have been sharing about, I guess, the sensitization of parents and carers to the importance of having the screening done, if we're not able to do it at the time that mommy is expecting, but once the child is born, how do you counsel a parent or parents who do not want to screen their children or newborn child at birth, particularly when you know they are in an at-risk category? How do you counsel them?
Yes. So one of the things I did not mention, is that the only question, or you have some more to ask? Maybe you can.
For now, yes. We'll get some more that are coming through.
All right. So one thing I did not mention is that this newborn screening program is actually riding on a very well-established HIV program where they are doing very intense counseling and testing for HIV. So we are actually riding along that. As parents are being counseled to have HIV testing done, we also ride along and also bring the story of sickle cell disease as well. And we have a huge success story within Zambia. This is something that has been published as well some time back, where the acceptance rate for testing is actually very high. And we thought we could actually add this to the HIV screening that is happening, or the early infant diagnosis that is happening in all health facilities. Right now, what is happening is that every child that presents to a health facility is offered, opportunity to have an HIV test done. And so we're doing the same thing to all the mothers that are coming with children that are less than 3 months old. We are offering sickle cell disease testing. And as soon as they accept, we go ahead, do the testing, and send the samples over to the central testing lab, and await results. And we, for the very short period that we've been running, we've screened over 2,000 children, and the reception of the counseling is very good so far. And we have parents who are very eager. Again, once we've tested them, they keep wanting us to find out, how soon they can come to get their results.
If I may, oh, that's wonderful. But if I may just add on a follow-on. So can we say then that newborn screening is mandatory in Zambia, or not yet at the moment?
Not yet mandatory. We are at the point where we are piloting, we are piloting. So part of it is just also to assess the acceptance rate of this particular disease. And fortunately also, we have a very proactive and several parent-patient support groups who were very much alive at the time that we're launching the program. So through their various networks as well, they have been spreading the news or the information that we have newborn screening happening within the country, have been spreading the word. And I bet that could be one of the reasons that we're getting a very high acceptance rate of testing amongst the parents.
Oh, fantastic. No, that's really very, very encouraging to hear. We have another question from Graham, who's asking, what effective cost methods are there in newborn screening? Yeah, what are the cost-effective methods in newborn screening?
Yes. So I had highlighted some of them as I was talking through the slides. Okay. I'll just go back to, that particular slide. Okay. So the simple cost-effective interventions that we're putting in place are that we are beginning these children on penicillin prophylaxis quite early, as early as 2 months, if we catch them that early. But within the program, we are allowing to go as late as 3 months, because around 3 months, we begin to anticipate severe infections, pneumococcal infections, and invasive pneumococcal infections around 3 months. So we are actually beginning the prophylaxis earlier than that, before that begins to happen. And then also we are introducing anti-malarial prophylaxis, as well as prophylaxis against anemia. We put them on folic acid quite early in life, and advising mothers, as they birth the baby, they should always be feeling for any swelling in the abdomen, because around this age, children are at a very high risk of having, splenic sequestration, something that a lot of parents have lost children from without having any idea what has caused the death of this particular child. Okay, so those are some of the cost-effective interventions. We are hoping within probably the next few years within the program, we can begin to introduce hydroxyurea quite early, around 9 months, around 12 months. And then we anticipate these children will have much, much less complications. They'll have less pain, less, episodes of anemia, less admissions to the hospital. That is the hope.
Fantastic. Well, we've been reminded that we're running out of time, but just one very last quick question. I guess, what would you say to a policymaker in any part of the world who doesn't see the need for newborn screening and the like, what would you say to such a one?
To such a one, I would say this disease is very common in certain areas. It's been reported. You can see the numbers that have been shared. It is a very common disease. It is also a lifelong disease that is very expensive to manage. So it would be prudent that we identify those that have it early, begin to manage them with very inexpensive, cost-effective interventions, which I have shared, than to wait for them to actually fall sick and have to spend much more to treat them, and not just in terms of what they would need to treat, but also the expertise to treat become more complex as they come with complications. So
That's
a
right.
child who's diagnosed early, put on low-cost simple interventions is relatively well most of the time, is one that can be managed by anybody, any health worker. It doesn't have to be a specialist. So it is important that we begin to, recognize that this is the disease which deserves much more attention than is actually being given right now. So I hope this particular program, the CONSA, can demonstrate, at least in these 7 African countries, and we can get buy-in of the Minister of Health in these particular countries.
That's right. Well, no, I can talk to you for a long time, Dr. Catherine. Really, really appreciate your time, your expertise and insights into how newborn screening, I guess you could update the rest of us in different parts of this world about what's going on in the newborn screening and the tremendous work that you all are doing on the ground, because sometimes we only hear the horror stories on our end, but unaware of the groundwork that is being laid and that is being done on your end. So to this end, I just want to say thank you so much for sharing your insights and your knowledge and your time. And we wish you all the very best in the work that is happening in the countries.
Thank you. Thank you. Thank you very much for the invitation to come and talk here. And I hope this is also serving as part of the awareness that should be happening in September, which is a Sickle Cell Disease Awareness Month. I hope we can spread word using this conference as well. Thank you so much.
Absolutely. Thank you so much. You have a good evening.
Thank you. Thank you.
Thank you all.